Okay, good afternoon, everyone. My name is David Corey. I'm the president of Apovia, and first I'd like to thank all of you for deciding to attend our Apovia 1-2 jab panel discussion that will involve a real-world experience on the rollout of COVID-19 vaccine at community health centers, as well as in other healthcare organizations, and to provide some insights on how government is actually playing a role in supporting this effort. But before I introduce our distinguished panel, I'd just like to share a couple of words about Apovia, which is a relatively new company, and I would imagine probably most of you have never heard of Apovia. Apovia is a company that basically specializes and only specializes in setting up and managing in-house 340B pharmacies. Our business offering really complements the medical home model by providing that one-stop shop for all prescription needs. Our philosophy is really to serve as a strategic partner to fulfill HRSA's goals for the 340B drug pricing program by enabling covered entities such as FQHCs to stretch those scarce federal resources as far as possible, reaching more patients and providing comprehensive services. Apovia's leadership has vast experience in building out and managing high-performing 340B pharmacies. We'll build out soup to nuts, design, build, and operate pharmacies for covered entities. And we could do that in a relatively quick turnaround time, as well as establish and build out medication dispensaries if that's necessary. This next slide just summarizes the key service offerings that make up our comprehensive service model. We could, through our pharmacies, provide retail, specialty pharmacy services. We do EMR-assisted medication reconciliation to optimize drug safety screening for drug-to-drug interactions, disease interactions, and dosage adjustments for patients who have kidney or hepatic insufficiencies. Also, we configure our pharmacies to have multiple patient access points to receive their drugs. So patients can either pick it up at the pharmacy, free home delivery by courier, or mail order. In addition, we also provide what we call integrated patient care pharmacy services, where a clinical pharmacist and a care coordinator actually work with clinic providers in troubleshooting and dealing with any kind of medication issues to help optimize medication usage for our covered entities patients. Our organization will also have a proprietary software called Compass, which serves as a dual role. It can provide comprehensive analytics to generate data to prioritize and help optimize 340B pharmacy opportunities. And it also serves another role as a platform for doing medication prior authorization services, where we'll do all the prior authorization and take that administrative burden away from our covered entity customers. And we've been doing that. We just rolled that program out over the last couple of months. So, well, that's in a quick snapshot of who Apovia is. And you know, if you're interested in more information, please visit our booth or go to our website, our LinkedIn, or follow us on LinkedIn, or email us, and would be more than happy to provide a comprehensive capabilities presentation. Now, before I introduce our panelists, I'd like to ask the audience, if possible, if you can mute your microphones and turn off your cameras. This way, it'll help feature our panelists on the screen for our panel discussion. Also, I just wanted to mention that if you have any questions, feel free to ask questions in the chat box, and we would be more than happy. If we can't answer them right away during the panel discussion, we'll follow up with you individually after the program. So at this point in time, I'd just like to introduce our distinguished panel. We have from Philadelphia, we have Dr. Janet Young, who is the Chief Medical Officer for Greater Philadelphia Health Action. From Wilmington, Delaware, we have Dr. Yvette Bemidou, who is the Chief Medical Officer for Henrietta Johnson Medical Center. And in Reading, Pennsylvania, we have Dr. Mary Kelleher, the Chief Medical Officer for Berks Community Health Center. We also have with us today is the Honorable Dr. David Shulkin, who recently served as the 9th Secretary of Veterans Affairs under the Trump administration, and also served as the Undersecretary of Veterans Affairs for the Obama administration. Prior to that, he had a very illustrious career in the private health sector, where he served numerous executive level positions. He is the recent founder of the U.S. Healthy Work, an organization that advises companies, universities, other healthcare organizations on COVID-19 prevention and vaccination issues. So panelists, welcome. Again, thank you for volunteering to be involved in this discussion with something I'm sure many of you are talking about every day in your sleep. But before I get into the questions, I'd like to just kind of mention a few key statistics that kind of allude or demonstrate how important it is, this vaccine. You know, as of yesterday, according to the Johns Hopkins Coronavirus Resource Center, the COVID-19 virus, since its emergence out of Wuhan, China, has claimed over 2.4 million lives worldwide and almost 490,000 lives in the US alone. Fortunately, as you know, in December, the FDA granted emergency use authorizations of 2 vaccines, one from Pfizer and one manufactured by Moderna. And these vaccines have been very effective, over 90% effectiveness in preventing the COVID-19 infection. Along with, you know, the supply of the demand for this vaccine is far out, you know, the demand is far outweighing the supply. But, you know, a robust distribution has actually been occurring. As of yesterday, 72 million vaccine doses have been distributed. 55 million doses have been administered, which close to 15 million of those doses were the second doses for patients that were receiving the vaccine. And because this is the supply demand is such an important issue, I'd like to get into the first set of questions relating to access to the COVID vaccine. And all clinics and providers, before even getting access, had to agree to sign a CDC COVID-19 vaccination provider agreement. And my first question is, I'd like to ask everyone, and I'll start off with you, Dr. Amadou, is accessing the vaccine, going through that administrative process of the contract, was that any major burden, or was that not a major issue in accessing, just to get vaccines to get started with your vaccination program?
Well, we struggled with some communication problems in getting that form completed, because we were given one form, we completed that, and then we were told that it needed signature by one person. Then, oh no, you needed a signature by the CEO, and the CEO signed it, and then or looked at the form and said, but this isn't a place for a CEO to sign. And we thought that our director of clinical services could complete it. So it took us about a week's time of back and forth before we could even complete the form, just simply because the state itself didn't really understand the form themselves.
I see. So I guess, and Dr. Kelleher and Dr. Young, you had a similar type of experiences or that kind of delay?
No, go ahead, Dr. Kelleher.
Sorry. It's always hard on this Zoom. We had a pretty seamless, that was probably one of the easiest parts of our process that we went through. So we had known that this agreement or possibility of agreement was coming, that FQACs were being viewed as part of the answer to vaccine distribution. And so we anticipated getting an agreement, and as soon as we had it, we completed it, and luckily enough that it went through as it accepted without too many obstacles here in Pennsylvania.
And we didn't experience any problems either. The way the form was set up under the Department of Health, it flowed easily. The electronic aspects of all the various signatures that they wanted actually worked. And they wanted a lot of data. So I was surprised at how much data they were asking for. For a vaccination effort this important, I think they probably went a little too far in that process. The enrollment form was quite long, but you know, if you had it and you filled it in, the approval came and it was pretty smooth.
Yeah, and David, let me just mention that, you know, the bureaucracy and sort of the paperwork is always the hard part, but you know, given the fact that we started this pandemic and for the better part of the year really didn't have a national policy or a national plan, this is really the beginning of it. You know, the government pre-funded all these vaccines, so there's enough, you know, nobody in this country should have to pay for the vaccine itself. The administration costs are different, but the government really does need the ability to be able to report on who got the vaccine and get the numbers. And so the purpose of the agreement is really to get the commitment of the organization who's receiving the vaccine to timely report it and timely document the administration in the medical record.
Thanks, Dr. Shulkin. Appreciate that. With that said, so it makes sense. The first time go around, I mean, even a week's hiccup, now that that's all done, the flow of vaccines there. The next question is how challenging are the requirements in maintaining access to the vaccine and the reporting? Now, obviously, like as I alluded to earlier, I rattled off statistics that came right from the CDC, and that's data coming from you, from the providers, with regards to the vaccine injections and so forth that are happening. But I'll start with Dr. Keller. How is it maintaining the requirements to gain access and maintain access to the vaccine?
I think one of the things that we strive to do is have a quality plan in place already for existing vaccination programs. So we've been participating in the Vaccine for Children program that comes with some requirements. So I don't think the ask were too much. We're used to, reporting it to the state. We're used to following storage and handling guidelines. We're used to collecting information, whether people are eligible for the vaccine or not. So I think it really was not, and it just reiterates the importance of having a quality vaccine program in place, because this became a new vaccine, but the processes were already integrated into her clinical services. So just making sure that we follow them was something that we always strive to do when it comes to vaccinations in general.
Okay. Dr. Young, your thoughts on?
I would agree with that. We had an existing infrastructure for immunization for children and for adults. We were already reporting vaccine data to the city. All of the Philadelphia data is automatically reported to the state, which in turn, of course, it all goes to the CDC. So we already had all of those processes set up. We already had full laboratory services. So this was actually more about managing the incoming doses, as opposed to our usual process where we establish an inventory and we order, and we keep our stock and we replace as we give. This process had to be managed in a kind of a manual fashion because, as Dr. Shulkin said, we're right at the beginning. These are the first doses kind of coming right out of the manufacturer. So they didn't actually, when I say they, the city health department did not actually start a routine ordering process yet. That's starting this week. So until we got to this week, it was kind of a week by week. Well, here's how many doses we can give you. And now that we have all of our sites up and running, we're vaccinating everywhere regularly. They now can anticipate better how much we need, how much we're going to order, and now we can order in the more conventional way, which is the electronic process. So we understand. I have a saying that we sometimes function on COVID time. And COVID time is odd. It compresses and it expands. And sometimes I think people have a sense that more time has passed than what has actually passed. So when things begin, everyone's very anxious for things to be like fully fleshed out and fully operational and thousands of people. And I have to keep reminding everyone, we just started. Okay, we just started. Like it was like a week ago, we just started. Okay, we've already vaccinated this many staff. It's only been 7 days. It's really okay, that the speed is actually fast. This is fast. And I have to remind everyone, we've never, to my knowledge, ever tried to immunize this many people at the same time. We're trying to immunize everyone in a very compressed time period. And when have we ever tried to do that? So some patience is required and some persistence, but I'm very pleased with how things are happening. And we've got patients already vaccinated, patients scheduled, wait lists. So I'm happy. We're just waiting for more doses.
Dr. Bemedu, how was your experiences with it? Was the same thing right now with supply or maintaining access?
Well, it's funny. I'm forever the optimist, but the obstacles that we've run into are somewhat expected and somewhat surprising. We too here in Delaware have an electronic reporting system that's already in place for vaccines for children as well as for adults. And so that wasn't new. What's new to us is the volume of folks that we're trying to get vaccinated in a shorter period of time. And so despite the fact that we have those accounts set up that go electronically to the state, in order to enter that data, you actually have to have your own login, your own license, so to speak. And that's where it gets a little bit tricky, because everyone wants to, so many nurses in Delaware want to come out of retirement to assist, and we are more than grateful. It's been a great grassroots volunteerism event, but the problem is that we can't get everybody a license to do it so that they can enter the data. So then you have to figure out different roles for them, but someone still has to enter the data. So we end up doing a lot of manual data entry, just simply because we're trying to keep up with the flow. We're still waiting for more doses ourselves. We've put in, and the poor state and the governor's office have done such a remarkable job with what they've been handed. So I do want to applaud them in the way that they've handled what's come to them. But the problem for them is that they don't know when it's coming, what's coming, and they've asked us to be patient. I'm on at least 2 to 3 calls myself a week, and we've decided divide and conquer, because every little organization wants to have a combined Zoom call. So we're Zooming all week long about vaccines and how to get them to the 65 and older community, and particularly how to get them to folks who live in underserved Black and Brown communities. And that's really been our struggle. And yet that's the population that we serve here at RFQHC. So it's been a challenge, and it continues to be a challenge, but I have to confess, it's such an exciting challenge, because so many folks are awake and ready and interested. And even those who start off not interested, if you have a one-on-one conversation with them with enough information, a lot of folks can change their mind. And I know the good that the vaccine can do, and I get to espouse that. So I'm really excited about how things are progressing. We just need more vaccine.
Yeah, David, I would just add 2 things. First of all, I think all the comments have been really good. That what I know that the Biden administration is trying to do is to give some more advance information so that people know what vaccine they're getting and when they're getting it, so that they can plan appropriately. And Dr. Young's COVID time advice, I think, is good. It just takes a little bit of time to work all that out. But for me, there have been really the unintended consequences that have been a challenge on the organizations. The 2 that I'm thinking about are the ones that have been in the national news recently. In Texas, with the terrible snowstorm and the power outages, who would have planned on the fact that you'd lose your electricity, not have generators, and now your vaccine is really threatened at being lost. And so watching people try to heroically save their vaccine supply and also try to distribute vaccine that is going to go bad soon as quickly as possible is certainly one stress on the system. Fortunately, that's not happened up here to us. But the second stress, I think, is on the staff themselves. And we have 3 remarkably calm leaders in front of us today. But it is stress when so many people are asking for the vaccine and you can't accommodate everybody. And we see, the story that sort of has been heartbreaking to watch is the physician, I think, again, in the South, that had his last supply of vaccine that was going to be expired and tried desperately to get it distributed, and in the end had 1 dose left over that was going to go bad, gave it to his wife who had pulmonary sarcoidosis, so she was at risk, but got fired the next day, and his whole career was essentially over. Now, he got cleared by a court of any wrongdoing, but still, to have your entire integrity and career threatened and your reputation ruined when you're really just trying to give vaccine to people and to help people, that that's very stressful on people. So we're putting our frontline workers who have already lived with this pandemic for a year under stress, under a new type of stress.
So it sounds like right now, is there the access of adequate supply that is not quite where we would want it? Is that what I'm hearing from everybody? Dr. Bemidou, are you able to get what you need, or is there, you're only getting allocations what they can give you?
We're only getting what they can give us. They,
Okay.
on one call, we were told that as long as you send in your form by a certain day of the week, like initially it was Monday, by later in that, and the next call that 2 days later on the next call, it was Thursday that the form had to be in order for you to get supply for the next week, which we adhered to. But that was, that was last Thursday, and it's now Wednesday, and we still haven't heard about our supply. So we still have a couple more doses to administer, a couple in quotation marks, this week. But come next week or the week after, it's we'll be down to twiddling our thumbs waiting for more. But I'm hoping it'll come next week, because the state is really doing a good job of trying to get vaccine out there. So I stay hopeful.
And Dr. Keller, the same issue with?
And I think what we have been committed to is not requesting more vaccine than we can distribute. So we have been conscious of the fact, because especially now that we're coming around second doses, one of the things that I think it's important to point out is vaccine did not come with staff to administer. So it didn't come with the National Guard. It didn't come with, federal, physicians. So we very quickly realized, wait, we have to staff the mass vaccination events that were given. So that staff had to be pulled from their responsibilities. So it had to be, pulled from their direct patient care and the chronic management of disease that is still going on. And that was tough. So we made a decision, because we realized the importance of vaccinating our community, to make that. But even that, we only could do so much. So we were very conscious to order what we could distribute. As we got better and staffed it better, we were able to request more, but we were able to receive vaccine for that. Now, we hope that continues. I think there's a lot of chatter of whether or not that will be continuing. Here in Pennsylvania, there was some discussions of misuse of second dose allotments being used for first doses. So we haven't yet faced that, supply issue. But I'm probably more nervous this week than I've been since we started, whether or not we'll get our allocated vaccine coming up next week.
Dr. Young, same experience with that?
In Philadelphia, we actually, I'd say GPHA, I only can speak for GPHA because I really don't have visibility on what's happening across the board. I feel actually confident about the doses we're going to receive. It's just that that number is not high enough to meet the need that we have. So we recently had a phase expansion, which is great. We started out with just vaccinate your staff. Then we expanded into, okay, start vaccinating patients, but they have to be this age and only these 4 diseases. So we just decided to call that a modified phase 1B because it wasn't all the diseases of phase 1B. And on Monday, they expanded the phase again. So we just announced all of this to our staff, and we're rolling it out. So I think the frustrating point here is the fact that we are rationing. I use that word with the staff because they need to get their head wrapped around this, a scarce resource. And perhaps because, I don't know what people are thinking, oh, we're in America, like we're supposed to have a lot of everything, but we don't. This is a scarce resource and we are rationing. Now, embedded in the provider enrollment document and in the CDC website is a threat, actually. And it says something like, if you are found to be vaccinating out of phase, you'll lose your access to vaccine. It's in there. I was surprised to see that, but maybe I shouldn't have been. And so this was a point of education for our staff. I needed the staff to understand that this is a national problem we're facing. It's all of us together. It's not about GPHA getting more doses than somebody else. That isn't going to happen. And this is rationing. It's not a matter of this patient needs it more than some other patient. It's just a matter of when is everyone going to get it, because all of our patients need it. And so we have to follow the rules. And if we don't follow the rules, we're going to get kicked out of the game, and we can't afford that. These are some bitter pills to swallow. And so we have constant requests from the staff. And I totally agree with Dr. Shulkin. It's a lot of stress in the staff, a lot of requests about, well, what about this patient? And what about this patient? And what about this group? Well, obviously they need to be vaccinated, but if we put them out of step with the phase we're in, we will jeopardize our ability to immunize anybody. So we can't take that chance. So we are almost walking a tightrope from week to week. And as long as we just keep one foot in front of the other, the rope is there, but this is very much a balancing act right now.
Any comments or thoughts on that as well? I mean, you brought up that case, that poor guy got destroyed, but then he was able to recover. But to Dr. Young's point, to walk that, everybody's trying to follow those strict guidelines, and it seems like there's pretty strong threat and punitive effects, and everybody's just trying to do the right thing. No one's really trying to abuse the vaccine.
Well, I wouldn't say nobody's trying. I mean,
Well,
the problem is, the problem is that I don't think we've ever had a health condition under such a microscope. I mean, every night on the news, or no matter what, however you get your news, it's COVID, COVID, COVID. So in a country as big as ours, it takes just a few bad actors, and that's going to grab all of the headlines. And then that begins to start eroding the trust between the medical community and people, because this is viewed as, rightly so, as a life and death situation with close to 500,000 Americans who have lost their lives due to this virus. So I think Dr. Young's right that you have to approach this with the seriousness that it is. You have to anticipate that anything that you do will ultimately become public knowledge. We're all human. We're gonna make mistakes. I was talking to health system CEOs earlier today who are being asked to now make decisions on whether people have the appropriate comorbidities or not, since they're now allowing some states to vaccinate people below 65 who have medical comorbidities. And I think most of us who have led systems feel that there's no way that we as healthcare professionals can appropriately be the gatekeeper for who has a morbidity or not. It's not fair to us to do. It's enough to give the people the vaccine safely. So mistakes are going to be made. Some people are definitely going to get vaccinated who probably skipped, further ahead in the line than they maybe should have otherwise. But we shouldn't all be tarred, because I think everyone is, in general, trying to do this in an appropriate way.
Well, it's funny, but one of the first things when this vaccine was announced, there was a lot of trepidation, even wanted to help people to receive the vaccine. And I want to address like the healthcare workers, for example. They're in that 1A group that were identified as to be one of the first groups to receive the vaccine. And a recent survey was done, and the majority of allied healthcare, like nurses, pharmacists, and technicians, were hesitant or weren't sure they wanted to receive the vaccine, whereas that survey, physicians and scientists were more open to it. I'm just curious what our chief medical officer seen in their clinics. How receptive was the vaccine with your healthcare workers, and did you have to do any educational efforts to overcome that? Dr. Keller, what was your experience with, as it was a new novel vaccine, was that a major concern for people who wanted to receive the vaccine?
Yeah, I would say additionally was. So we did a pre-survey when we were anticipating vaccine and we had 8 yeses. And I was like, 8? And that's a staff of like 200. And I almost had a heart attack. I was like, wait, we have work to do. And there was work to do. There was education for, for staff members. There was education for people to understand what the vaccine was about. And I want to make it clear, it wasn't just like support staff that was saying no. We had a group of physicians. We have a group of physicians and nurse practitioners who happen to be of African American descent. And initially, in the first, distribution of interest, not one had said yes. And so I needed to identify what were the barriers to them accepting. Some had come from African countries where there was this historical distrust of new medical interventions, and they were raised to kind of know that things were, experimented on people of color, and that distrust was real. So we had to look at that and then have conversations about that history, because these were educated people. These were people who knew about vaccines and the importance of vaccine, but were still saying no. And as we broke down those barriers, it allowed them to also recognize that they could break down the barriers for other patients and patients of color who might be reluctant to get the vaccine. So we currently have around over 50% of our staff, closer to 60 now, who have now accepted it. But there was also a lot of wait and see. I think there was a lot of wait and say what happens to other people before I say yes. So we make sure it's known that just because you say no doesn't mean that you can't change your mind going forward.
Well, that's interesting. And Dr. Young, did you see the same type of hesitancy with that? I will say, Dr. Keller, it sounds like you made great progress in knocking down some of those barriers, and it may continue to evolve that way. Dr. Young, what was it like at GPHA?
We did not survey first. We did a massive education program. So all levels of staff, and we have an online platform for learning. So we put everything there so we could have everyone log in and document that they got the education. So as it rolled out, and I guess my philosophy on this is that we really need to immunize everyone who wants it urgently. So I said, so let's just go, let's educate everybody and let's just get going. Let's start vaccinating and then let's see what happens. So at the end of the campaign, we had 60% of staff immunized. So 40% are not. Now in that 40% are a few people who were recovering from COVID infection, a little too soon to get vaccinated. We had some staff that got vaccinated outside of GPHA and they haven't been tallied in, and but we're probably around 62%, something like that. And we're going to circle back because we need to address vaccine hesitancy as a total project. We have a team of providers working on vaccine hesitancy, and like Dr. Kelleher's comment, we have providers that didn't get vaccinated. So this isn't just about support staff. This is the whole staff. It's like there are just people who want it and people who don't. And so we're going to go back with a program about hesitancy. For right now, our infectious disease specialists are doing one-on-one discussions with the providers, because how are we going to be able to really reach our patients if the providers are not confident about this? So we're doing a one-on-one. So that's kind of, we chose to take that route to work on them first.
That's excellent. Sounds like initial challenge, a lot of progress and still evolving. Dr. Bemadou, what was your experience? I know anecdotally, Dr. Bemadou, that I was down there and the person who got the vaccine got it because you got the vaccine, and you made me feel comfortable with that. But go ahead. How was it moving at Henrietta Johnson Medical Center?
Yeah, if I had it to do all over again, I would probably do it differently. But I sent out pleading emails. I call myself the song and dance woman, and I sent out these 2 emails just beseeching my staff to get vaccinated and why. And with that, we had a minimal response. We later did an all staff Zoom call where I just did education, and it felt very intimate because we're a small organization, where I got to actually educate everybody on the virus itself and how the vaccines work and how safe they are, and educating them that despite getting a vaccine, this is, the virus itself never enters inside the nucleus of your own cells, so it doesn't become a part of your DNA, and you're not given virus, so to speak. Your body extrudes that core protein, and yay, hooray, your body is smart enough to fight off the invader. And I had folks come up to me after that discussion who said, I would have gotten this vaccine last week if you had given that talk then. So looking back, that's probably how we should have started instead of doing it into the vaccine campaign. So to date, we have about 60% participation, and we're still keeping it open for folks who might change their minds. And we do have a staff member who has some long-term effects from COVID-19, and dare I say that this was probably not someone who got vaccinated, and that breaks my heart. But we move forward, and I continue to encourage.
Thank you, Dr. Bamidou. Dr. Shulkin, what have you seen in other organizations with regards to the acceptance?
Yeah, I think we're seeing around the country about a 60% vaccination rate. And I have to tell you, this is the thing that surprises me the most. I simply didn't expect it. I thought that we would see among healthcare professionals a much higher acceptance rate. Especially, these are the people who have seen the 500,000 Americans who have died, and the many hundreds of thousands more who have been in the hospital and gotten sick. And so it is somewhat surprising, but I think the approach taken by everybody on the call is the right one. And it's really encouraging to hear that people, when they do receive education and information from people that they respect and trust, do have their minds changed. And so maybe that was a little bit naive on my part, thinking that this was going to be quick. This is probably, like everything else with health behaviors, more of a journey. It's not a sprint. It's a longer term marathon, and we have to just stick with it. But I think my view was, I was a health system CEO at the VA. I felt that we needed to mandate influenza vaccines. And of course, our schools have mandated vaccines for children. So if this wasn't such a new vaccine that had an EUA instead of being approved, I personally am on the side that we should mandate this. But of course, since this is really an EUA, we don't have the safety information the way we would on other vaccines. It's probably not realistic to see this being mandated in 2021.
David, if I could also, one of the things too, just on a personal note, when I had the vaccine, I was one of the unlucky ones to have a pretty severe reaction. In case if there was the check boxes of all the things that could occur and how you felt, including fever up to 103, I checked them all. So at home, I had to miss work and I had to say, oh my God, I just convinced all these people to get the vaccine, and do I tell them how bad it made me feel initially? And I did. I took a picture of my thermometer, I sent it to my staff, and I said, this is my reaction. And I did that for a couple of reasons. One, I think it's always to have honest disclosure. Two, to convince them that it didn't change my mind and I was still 4 weeks later going to get my second. And three, to convince them of the importance of coming back for their second, because half vaccinated healthcare force is not going to be our ultimate goal. And so I did, make sure that people understood, yes, you may get a reaction to this, but it still is important to complete the series. And just being honest with people about that, I think convinced people. And then if people did have a reaction, they would say, yeah, did you see Dr. Kelleher's email? And, you know, they were not as surprised when they had an honest explanation for that the vaccine may cause some reactions. And it was gone within 48 hours and I was back at work, but I did share that with people to encourage the vaccination.
Excellent. That's playing a leadership role. Now it sounds like this is a very resource intensive process. I'd like to get some ideas on how much of the resources is taken away from your day-to-day care. Is it how impeding has it been to roll this out at the same time maintain your regular care for your patients? Dr. Bemedu, can you comment on that?
Yeah, it has been quite the challenge. In the midst of COVID-19 vaccinations, we're still maintaining COVID-19 testing and flu clinics. Don't forget about the flu. So, in the midst of maintaining all of that, we're then having to figure out how to administer this new vaccine to folks. So it's been quite the challenge. There have been support financially to try to assist us, but the limitations on the support have been so challenging in and of themselves. But we, as of yesterday, were given enough to hire actually another temporary part-time staff member to assist with the vaccines, because it's hard to rely on voluntary staff because there's no real skin in the game. If you're a volunteer, you're there and then you're gone. And we needed someone committed that we could train who would own a portion thereof. So we're pretty excited to have that add-on.
That's excellent. Dr. Keller, how impactful has this been impeding the delivery of care is it running the same type of?
And we had to, I have to give a call out to my CEO because she understood the importance of meeting the call to vaccinate our community. So she supported, the allocation of staff to do so. We were able to do a vaccine clinic on Saturday, which was able to have a lot more people come in, for which providers, including my physicians and nurse practitioners, volunteered. And the CEO made a commitment to pay staff overtime to come in. So we did have leadership support in meeting that obligation. Doesn't mean it was easy. And as it goes on and you realize that this is not a 2-week project, I think, we have been able to look towards the federal government to help support federally funded community health centers with some funding to do this initiative. And that's very grateful, because I do think there would come a time where those financial costs would start to really put pressure to meet the demand that is out there. So we're very grateful for the federal support to meet this initiative.
That's great. Dr. Young, your thoughts on the impact on the delivery of care? As it seems, a lot of resources are going toward this.
It's significant. It is significant. I think the amount of work associated with the pandemic, because I think, I don't know, my observation is the agencies we work with, the federal government, outside organizations, everyone expects business as usual. Right. This is not business as usual, but that's what everybody expects. So it's like, the report is due, bang it out, bang it out, bang it out. I would say that this is one of the most exhausting periods of time we have ever worked through. And I am so grateful to have the team that we have, amazing, committed people who just roll up their sleeves and they dig in. But that is not sustainable over long periods of time. Right. There's pandemic associated distress around our patients who have died, our patients who've been in the hospital. The amount of clinical work has not changed, but we had to flip the entire practice to have a telehealth service, which is, I'm glad we could do it, but telehealth brings its own set of challenges. We have some other projects. We got funded for prep services, and it's like, well, just, you just do it. You've got a triennial report, you've got data, you've got to get this and that. Like, it just doesn't stop. I would say pandemic work combined with the vaccine, it's all a big ball. It's the COVID testing, it's the patient services, and the vaccination services have added several hours per day. It's not uncommon for huge numbers of staff to work 8, 9 o'clock at night. And I see the emails are like, they're coming in. People work on the weekends. At some point, this is going to have to be managed differently. So it's not just about the vaccine. I'm looking at this as like the whole pandemic package.
I'm just wondering, have you been able to work with any pharmacies or in helping support your vaccination programs? Your contracted pharmacies or I know some of the community pharmacies are getting access, but I think that's just for people who will sign up for those programs. But has that been of any impact or help? Have you been able to get any help through that?
Well, I think for what I'm talking about, pharmacies actually could not help us with that.
Right.
And the pharmacies are, I think, a great adjunct to what we need to do, because that's going to allow access for those individuals who utilize pharmacies well for immunization services. Great, I love it, because that's going to have a lot of people like going their way. We have a different job to do in underserved communities where the pharmacy is not necessarily going to be the best place. So all of the various entities involved in vaccinating, I love it. This is a massive public health effort. I'm actually talking about the cost, the personnel cost to GPHA, that it is significant. And we have to maintain clinical services while we are doing the pandemic package. And it's not just about vaccination. So I just wanted to give an honest answer to that question. I can't sugarcoat it. It is what it is. And we are constantly looking for ways to streamline, make things more efficient, save time, prioritize better. We're pulling out every management skill we've got to make sure we can keep things moving forward smoothly. Having more staff, that's more people to manage, by the way. Okay, so the more you add, that's more management work, that's more supervision, that's more. So we need more staff to ramp up to a higher level of immunization power, but that also brings additional responsibility. So that's unavoidable. It's a pandemic, it's unavoidable.
Understandably. It sounded like though the federal government has been supportive and adequate for financial resources and bring in new staff. That's been helpful. It sounded like from what I heard. Is that
we haven't received anything yet? We have not. So there's some funding coming. I know it's coming, and then there's another bucket of money that we need to apply for, but we haven't received anything yet. We're working off of the resources we currently have.
I see.
Yeah.
Good luck.
No, I was going to agree with Dr. Young that the funding that is committed to help is in the stimulus bill, which of course we're watching to see whether one can be passed out of Washington. So hopefully that will happen. And of course, you can charge administration fees that in general average, about $24. And so you have to bill for that and collect for that to be able to help offset your costs.
Yeah. The only issue with administrative fees, especially for folks who, we want to vaccinate everyone in our community, and they may or may not be our current patients. We want them to eventually be, because that's our goal, to serve the community. But the problem is that then you have to collect the information, and then you have to do the billing, and that too is another set of responsibility. And as an FQHC, in order to do that billing, you have to decide whether or not they're going to be a part of your database and part of your unique encounters. And so that too has its own set of concerns. in getting folks vaccinated. And really, if the goal is to get them vaccinated, so unfortunately, you end up eating the cost of that administration most of the time.
Mhm.
Well, you know, as a pharmacist, these vaccines are very unique in their nature and with their preparation, stability, storage, and timing of injections. There's so many things you got to juggle with these vaccines. For example, the storage of them, some have to be stored below. I never knew of a pharmaceutical that had to be stored below, 50 below zero, with the Pfizer product. How challenging has been dealing with the preparation, administering, and timing scheduling vaccines? Dr. Kelly, or can you offer any thoughts on how you've been able to deal with that, or has that been pretty?
Yeah, we've progressed through this, but it's been a learning process for us. So naively, we scheduled patients for the vaccine, and then very quickly realized that we had vaccine left over, and we were like, wait, we didn't schedule in batches of 10. We have the Moderna, and so we was like, wait, we have to schedule in 10s, and then you have no-shows. And so, I have made it clear to my staff, and they understand that no vaccine goes unused. So we're trying to plan for vaccines. You always have people who no-show. You may have people who unexpectedly show up who are, I had a 95-year-old man show up at our vaccine clinic. My staff turned to me and said, he's not on the schedule. I go, well, now he is. He's 95. He made an effort. We're not sending him out without a vaccine. Maybe we had a no-show, and then at the end of the day, we had vaccines left, and we find an arm to give them into. So we've gotten better. We schedule in lots of 10. We have an emergency call list for last minute. We tried to plan, but we didn't start that way. So we started in panic mode with a call to myself and we have 2 vaccines left. And I said, go to the parking lot if you have to. We're going to find an arm to give it to then more organizing the end of the day vaccines to, an appropriate person, and making sure that we're scheduling in blocks that correlate with vaccine shelf lives and how many vaccines we have for the day. So we've learned, we've done better, but it was initially challenging to meet the requirements.
Dr. Young, how was it GPHA? I know, how was the same issues with the scheduling? And
We had a great rollout. I have to give a shout out because I saw Sarah Lai's name show up on the panel somewhere when I was logging into the Zoom. Sarah Lai is the Chief of Health Center Administration. She's a member of our epidemic management team. We have a team that oversees every aspect of what we have to do to manage COVID. So the meticulous planning, the training, the wait lists, the whole flow of how patients end up getting an appointment for vaccination was laid out in advance and communicated and trained on. And so as we started setting up sessions, we kind of replicated, and we had a great rollout. We had an amazing rollout. So we just now have expanded it. So we just moved it to more facilities, and now we're increasing the hours and we're increasing the doses. So we really had a very good experience with the rollout.
that's excellent. Dr. Bemadou, how was things when rolling out with the doing all the scheduling, this juggling with the mixing, and very unusual. As I said, as a pharmacist, I never knew a pharmaceutical that came with these types of storage and mixing requirements and stability times that had to be coordinated in scheduling and administering the drug.
Yeah, true. Well, I'm blessed that Delaware is so small that, and I've been in this community for over 20 years. So it wasn't hard when we fell short with our planning and someone didn't show up and we had extra doses for us to find an office that needed somebody to get vaccinated. Or again, collaboration has been our friend, and we've had lots of friends who are now vaccinated, 1A, 1B friends. And we also keep a group of folks on standby. Before we could roll into the 1B section, we had some frontline folks who were on standby. And so our goal was not to let a dose go unused. There was one dose that did get unused, and I have to confess that dose still haunts me to this day. But after that happened, we vowed never to let that happen again.
That's
So
Dr. Shulkin, have you seen things across the board in other organizations with this? Any unique challenges, or pretty much the same type of, I mean, it's a very unique pharmaceutical product in the preparation scheduling.
Well, I think in many ways each vaccine has its own challenges. The Pfizer vaccine, which has to have a much colder freezer requirement, did require the special purchase of freezers by many organizations, and that favored those that had access to capital and access to a relatively limited supply of those freezers. So the FQHCs and the local pharmacies, I think, weren't in the same position, at least to take the Pfizer vaccine. With the Johnson & Johnson vaccine that got EUA from the World Health Organization, not yet from the FDA, I think that's going to even make it easier because it can be stored in a regular refrigerator. It's single dose vaccine. So I think we're going to see this situation get much better and get out into the communities with greater ease.
There's so many things I like to ask, and we're really at the end of the limit here with time for questions. But one thing I don't know if we can quickly address, there's starting to get a lot of news in the media about mutation variants of the vaccine of the virus. And I'm just curious, is that something on your radar screen you're following, tracking, not to make the COVID story get any more grim and to continue on, but it's something that's being reported upon. It's still up in the air whether these vaccines will be able to cover for some of those variants. Dr. Bemidou, what's your thoughts, or is that something you're tracking?
Right now, it's more an academic exercise for
Right.
us than it is anything else. I'm keeping myself aware and abreast so that I can answer the questions for my staff and for my patients. But right now, it's truly more academic than it is useful at this point.
Dr. Kelleher, any thoughts?
Yeah, I think when you it is something I worry about. I think we all as medical professionals worry about it. But what can we do about it right now? And what we can do about it right now is decrease community transmission as much as we can, which means vaccinating as many people as we can. So what can we do to prevent that from becoming a major problem is continuing the path of what we're doing, is vaccinating our communities in as high a number as we reasonably can so that community transmission goes down. Because as community transmission goes down, it's less likely for those variants to take hold and start to, really have a negative impact. So continuing our goal is what I see our role in preventing those variants from taking a hold and really, causing harm. So it does, it is on my, horizon as everybody else's to hope that doesn't occur. But we just got to continue doing what we're doing and vaccinating as many people and preventing community transmission. As we talk about vaccines too, we don't want people to not do what else we're talking about: social distancing, wearing a mask, washing your hands, limiting gatherings, that's just as important. And so constantly giving that message and reinforcing that message is our biggest role in preventing those mutations from taking hold in our communities.
Advice. Dr. Young, we were pretty much the last time. The last comments.
Well, I totally agree with my colleagues. I mean, the mutation topic is an education opportunity.
Okay.
Because unbridled replication is what leads to mutation. And so I think it's an opportunity to educate on why we have to put more effort into getting the brakes on viral replication through all of the public health measures that Dr. Kelleher just described. And so I will leave it at that. I totally agree with my colleagues.
Dr. Shulkin, any last couple seconds?
Just briefly, I think the comments have been good. I think the US is grossly under genotyping the virus. So we have just a very poor biosurveillance system in this country compared to other countries. Secondly, the vaccine itself, I think we have pretty good confidence probably will cover the current variants that are out there, because it's designed to create antibody to the entire protein spike, where what a mutation is just a few replacements in the DNA itself. So the vaccine doesn't react at that level, it reacts at the full spike level of the protein, and that probably is going to continue to have good protection.
That's great to hear. Well, at this time, we're right at the end. Maybe we've gone a little over, but I just want to thank our panelists for a great discussion and sharing that your real world experiences and your wisdom in dealing with the challenges with the role of the COVID-19 vaccine. There's no question we're all in this together. We got to fight and help and everyone to be successful in defeating COVID-19. I also want to thank all of our attendees out there who attended our meeting through the cloud. If you have any questions, feel free to forward them to us. We'll respond individually. And at this time, thanks again.
Okay. Thank you.
Thank you.